I know this isn't your first time hearing a talk about lymphadenopathy, so let's make this talk different and interesting. Instead of going through basic examination techniques or listing every possible cause, we'll focus on answering three important questions. Question 1. Should we be concerned about this lymphadenopathy? Question 2. I'm concerned. What steps should I take next? Question 3. So you've made up your mind that you have to do a lymph node sampling. How are you going to get to it? We'll use what I call the what if approach. This helps us figure out how likely it is that a swollen lymph node might be caused by a cancer. We do this by looking at the patient's medical history and risk factors, paying attention to when and how quickly lymph nodes enlarge, recognizing that warning signs like fever, night sweats, and weight loss serve as valuable diagnostic indicators rather than mere symptoms. For patients with a known malignancy, lymph node enlargement may indicate disease recurrence or metastasis, which simplifies the diagnostic approach. For patients with a history of autoimmune disease, there are several important considerations. Even though these patients have autoimmune disease, we need to watch carefully for any signs of cancer. Autoimmune diseases like rheumatoid arthritis, SLE, and Sjogren's syndrome increase cancer risk. Rheumatoid arthritis patients have higher chances of developing lymphomas, especially DLBCL, and lung cancer due to chronic inflammation. Disease severity and treatments like methotrexate or TNF inhibitors can further increase these risks, though these medications remain essential for treatment. SLE patients have higher risks of blood cancer, especially non-Hodgkin lymphoma and cervical cancer due to HPV susceptibility. Regular screening and checkups are particularly important for patients on immunosuppressing medications. Sjogren's syndrome has the highest risk of lymphoma among autoimmune conditions, particularly malt lymphoma. Watch for swollen salivary glands and symptoms like night sweats or weight loss. Speaking of immune system function, let's turn our attention to another critical aspect, understanding whether the patient is immunocompromised or has chronic infections. Coexisting conditions in lymphoproliferative disorders. TB and lymphoma share common symptoms like fever, weight loss, and swollen lymph nodes. They can occur together or one after another. To tell them apart, we need tissue samples through biopsy and specific tests like PCR for TB and special stains for lymphoma. If you've diagnosed tuberculosis and started anti-tuberculosis treatment, but the patient isn't responding as expected, it's time to reassess. Reconsider your diagnosis, conduct additional imaging, and pursue a definitive histological diagnosis. EBV is closely linked to lymphoproliferative conditions, especially in immunosuppressed states. In post-transplant lymphoproliferative disorder or PTLD, reduced immune surveillance allows EBV-driven B-cell proliferation, leading to conditions ranging from benign hyperplasia to aggressive lymphoma. Castleman disease, especially the hyaline vascular type, can sometimes overlap with malignancies. IL-6 and HHV-8 are key players in its development. Kikuchi disease can coexist with Hodgkin or non-Hodgkin lymphomas, sometimes preceding or occurring simultaneously, so expert pathology review and close follow-up are crucial for identifying any potential lymphoma association. Let's talk about how occupational and travel history can clue us in when evaluating lymphadenopathy. For healthcare workers, including doctors, TB exposure is a key concern due to frequent contact with infectious diseases. Travel history to regions like Southeast Asia or Africa adds context, pointing to infections like TB, HIV, or parasitic diseases. Now shifting focus to physical examination, a thorough lymph node assessment across all regions is crucial, along with checking for hepatosplenomegaly. Don't forget to examine the skin for rashes or lesions and evaluate for any constitutional signs like fever or weight loss, as these can provide vital diagnostic clues. Knowing lymphatic drainage patterns is essential for predicting metastasis, guiding surgeries, staging cancers, and planning radiation. It's a good reminder to refresh our anatomy. It's the backbone of effective cancer management. Pattern recognition beyond size. Lymph nodes under 1 cm are often benign, but when they are larger than 1 cm, it raises suspicion for more serious causes like significant infections, inflammation, or malignancy. Next, look beyond size and focus on patterns, whether the lymphadenopathy waxes and wanes or steadily progresses, how it responds to antibiotics can offer valuable diagnostic clues. When assessing lymphadenopathy, consider if it's localized, pointing to a nearby infection, or generalized, suggesting a systemic process, and note whether it's symmetrical or asymmetrical for diagnostic insight. When examining lymph nodes, their consistency, mobility, and surrounding tissue changes like squishy for infection, rubbery for lymphoma, or hard and fixed for malignancy provide crucial clues about the underlying pathology. Tenderness and warmth of lymph nodes can signal an acute infectious process, while non-tender nodes often point to a slower chronic process. Important details for understanding the underlying cause. Look for skin changes, regional vascular patterns, and how the lymph node relates to deep structures, as these details can provide important context for the underlying condition. These pattern recognition skills directly lead us to our next crucial topic, the red flag matrix. Pay attention to red flags such as inconsistent lymph node responses and new symptoms that develop during observation. Rapidly growing, fixed, hard, or persistent nodes, especially more than 2 cm, or in supraclavicular areas, are red flags that warrant urgent evaluation. Unexplained weight loss, drenching night sweats, persistent fever, and worsening fatigue are key systemic red flags that demand thorough investigation. Atypical patterns like non-contiguous nodes, asymmetry, or unexplained organomegaly are red flags that suggest a need for further investigation. Unexplained lymphadenopathy in patients over 40 with prior malignancy or immune compromise are high-risk factors requiring careful assessment. Laboratory red flags like unexplained cytopenias, elevated LDH, or abnormal inflammatory markers can point to high-risk conditions and should prompt further evaluation. I'm concerned. What steps should I take next? When lymphadenopathy raises concern, determining the most appropriate tissue sampling method becomes crucial. Many clinicians, especially in peripheral settings, face challenges in this decision-making process. A common pitfall occurs when doctors perform an FNAC, receive a reactive lymphadenitis result, and prematurely end their investigation only for the patient to receive a different diagnosis months later. Diagnostic techniques: choosing between FNAC and core or excisional biopsy. Let's start with the least invasive approach, FNAC. It's a quick, minimally invasive and cost-effective outpatient procedure with lower risk, making it a great first step for lymph node evaluation, especially with flow cytometry support. FNAC is ideal for suspected metastasis, thyroid nodules, superficial nodes, or as an initial screening in elderly or high-risk surgical patients. When FNAC results are inconclusive or when we suspect certain conditions, we progress to more definitive methods. Core or excisional biopsy is best for suspected lymphoma, non-diagnostic FNAC results, and cases needing extensive molecular testing or deep-seated lesions requiring imaging guidance. Excisional biopsy is key when lymphoma is strongly suspected, detailed architecture is needed, or less invasive attempts have failed to provide a diagnosis. When examining a lymph node, we look for normal structures like germinal centers and follicles and watch for malignant changes like architectural effacement or nodular versus diffuse patterns. FNAC is great for initial evaluation, but it can miss architectural details crucial for diagnosing conditions like lymphoma. Even with a core biopsy, there's a risk of sampling error, especially in Hodgkin lymphoma, where the biopsy might pass through the inflammatory background without capturing the key Reed-Sternberg cells. That's why excisional biopsy is often the gold standard for cases with high diagnostic complexity. Now that we understand the importance of proper sampling, let's address our final question: how do we access these lymph nodes? The four main lymph node groups commonly biopsied and easily accessible are cervical, axillary, supraclavicular, and inguinal nodes. But what about the rest? Role of PET-CT in guiding lymph node biopsy. PET-CT highlights FDG-avid, metabolically active nodes guiding biopsies, distinguishing reactive from malignant nodes and aiding surgical planning. When using PET-CT, target nodes with the highest SUV, ensure accessibility, avoid necrotic areas, and leverage it for real-time guidance during procedures. PET-CT has limitations, including false positives in inflammation, low uptake in indolent lymphomas, small node resolution issues, and cost or radiation concerns. Approach to mediastinal lymph node sampling with a focus on EBUS-TBNA accessible stations. EBUS-TBNA provides access to key superior mediastinal nodes like upper and lower paratracheal nodes 2R, 2L, 4R, 4L, allowing precise sampling along the trachea and major vessels for diagnosis. EBUS-TBNA also accesses subcarinal node station 7 located below the tracheal carina and hilar node station 10, which are closer to the lung lobes and slightly more challenging to sample. EBUS-TBNA is a minimally invasive outpatient procedure offering real-time sampling of multiple stations with quick recovery. However, surgical approaches may be needed for larger tissue samples or if EBUS results are inconclusive. Extended mediastinoscopy is less commonly performed but allows access to subaortic station 5 and paraortic station 6 nodes, which are key for evaluating metastasis from left upper lobe tumors. EUS accessible lymph node stations. EUS-FNA provides excellent access to inferior mediastinal nodes including subcarinal station 7, paraesophageal station 8 and pulmonary ligament nodes station 9, often offering better visualization through an esophageal approach. The EUS approach offers superior visualization of inferior mediastinal nodes and complements EBUS for full staging while also assessing posterior mediastinal structures. However, it requires specialized expertise, distinct patient positioning, and often works best when combined with EBUS. Laparoscopic guided lymph node biopsy. Laparoscopic guided biopsy is ideal for deep-seated lymph nodes like retroperitoneal or intra-abdominal nodes, especially when CT guided approaches are risky or when larger tissue samples are critical for accurate lymphoma diagnosis. The whole patient algorithm clinical workflow. When evaluating lymphadenopathy, take a whole patient approach. Consider concurrent conditions, individual risk tolerance, and the impact on quality of life to tailor the diagnostic strategy effectively. When managing lymphadenopathy, a dynamic decision-making approach is key. Knowing when to observe and when immediate action is necessary ensures timely and appropriate care. In high-risk patients, lymph node biopsy might be avoided if severe comorbidities, bleeding risks, or extreme frailty make the procedure unsafe, requiring alternative diagnostic strategies. For high-risk patients, lymph node biopsy may be avoided if the nodes are deep-seated, near vital structures, or require extensive dissection, as these factors significantly increase procedural risks. This brings us to some exciting alternatives. Liquid biopsy using ctDNA is a minimally invasive option that provides mutation insights and allows serial monitoring. However, it may miss early stage disease, struggle to distinguish tumor types, and has limitations in certain lymphoma subtypes and clinical scenarios. The liquid core 52 gene panel, for example, uses NGS to detect actionable mutations from a simple blood sample, enabling personalized cancer therapy and monitoring. A high quality tissue sample is essential due to the extensive molecular testing required. Molecular testing from flow cytometry and PCR to advanced NGS panels play a critical role in decision making by refining diagnosis and guiding targeted treatments for lymphadenopathy. Latest innovations in lymph node access. Building on our discussion of patient-centered care, let's look at how recent innovations are making lymph node access more precise and less invasive. Technologies like robotic assisted dissection and GPS guided bronchoscopy or ENB enhance precision, minimize invasiveness, and speed up patient recovery. These advances continue to evolve with fusion imaging and AI assisted lymph node mapping, further enhancing biopsy accuracy, while single port VATS offers a minimally invasive single incision approach. Thank you for your time and attention.